covers and so forth are done on is not a 64 slice scanner. That's a much older scanner. We have a 256 slice scanner. But it's with a 64 slice kind of standard scanner that you would see in most hospitals. There's a 40 millimeter Z axis, which is the Z axis is really just kind of like the length of the chest. And it's done at a specific slice thickness. And so for each heartbeat on a 64 slice scanner is going to cover about 40 millimeters. So with a 64 slice scanner, it's going to take multiple heartbeats to scan the whole length of the heart. With the scanner that we have at Maine Medical, it will actually cover the whole length of the heart in one beat. And that's just because we have a really nice and fancy scanner. But if you're somewhere else, you're going to have probably a 64 or 128 slice scanner. The temporal resolution, you don't really need to know this, but the temporal resolution depends mostly on the gantry speed. And it's actually pretty good temporal resolution. And this depends a lot on your scanner. And the slice thickness for these is actually a pretty thick slice. So this is a much thicker slice than we use for our coronary CTAs, but it's done in a standard method. So even though we can get thinner slices for calcium score, we actually put back the thickness because of the method that it's done and how it's been validated. And the KVP is about 120. So that results in a radiation dose of about 1.5 millisieverts or 0.5 to 2 millisieverts, which it depends a little bit on your scanner. And this depends a lot on the patient size. If the patient is bigger, they're getting more radiation. It just takes more photons to get the radiation through them to get an image. And when you drop the KVP down, you basically get brighter calcium and it changes the calcium score. And that's why it basically has to be done exactly like this. This is how it's been validated. So even though we could do this with a lot less radiation, this is how the scoring's been done and how it was done for decades. And so that's the way it's validated. So a typical CT scanner has 512 columns and 512 rows or pixels. So you basically cone in on the area of the heart. This is an axial slice through the heart, and you can see in the center is the aorta. And then you have around there the left atrium kind of towards the bottom. And you're only seeing here one of the coronary arteries, which is the right coronary artery coming off. So the method for scoring is the Agatston method. Arthur Agatston is the same guy who popularized the South Beach diet. He's a cardiologist from Florida. But he also came up with the Agatston scoring method in the early 90s. And so the way this is done is that there's basically a weighted sum of all of the spots of calcium that have a density above 130 Hounsfield units. Hounsfield units are the way things are measured on a CT scan, whether you're looking at a abdomen or a chest, it doesn't matter. They're all basically measured in relation to this thing called Hounsfield units. And calcium is really dense like bone. So it has a really high number for the Hounsfield unit. So anything that reaches that threshold of 130 is counted as calcium. And then basically there's this kind of weighting factor for how many, like how dense it is. So if it was like 200 or 250 Hounsfield units, that little area of calcium would be multiplied by a factor of 2. And basically you're just counting up all of the pixels that are bright, adding them up and using this weighting to come up with a calcium score. And it's basically, yeah, just the area of the plaque times the weighting factor equals the lesion score. And then you add all of those up and you get the total coronary calcium score. And it's that total calcium score that's what we use. So for any given patient, you'll usually get a report that will show calcification in the LAD, the RCA, the circumflex, and then it will say the total score, and it's the total score primarily that's used. So this is an example here. You can see on the left, this is one axial slice through the heart, and I've circled the area of calcification. And so for this specific one, if you were looking at this, you would say you could calculate the lesion score for that specific lesion, and the Hounsfield units in that area might be 220, 183, 195. So you count up all of the pixels that have basically a Hounsfield unit over 130, use the appropriate weighting factor and come up with a lesion score. So for this particular one, the lesion score would be 14. And you basically just do this for each slice. You go through and circle them, and then for each slice, you come up with the lesions and basically add it up and get your total calcium score. Fortunately, there is software that helps with this. In reality, the radiologist just kind of goes through and puts a circle around anything that's calcium that's actually within a coronary artery, and the computer does the calculation. There's also something called a calcium volume score. This is another method that's used, and in this, instead of using kind of these thin axial slices, this is based on the volume of each voxel. As you can imagine, a CT scan is actually obtaining volumetric data. So it has, each slice has a thickness, it has a length, it has a depth. So each little spot within a CT scan is actually a volumetric measurement. So you can see here on the right, like each one would be a voxel or a 3D box. So you can calculate a calcium score in another method by multiplying the number of voxels that have a Hounsfield unit greater than 130. Again, that 130 is used as the cutoff, and come up with a total volume of calcium. So this is another method of doing it. There are some issues with this method. One is partial volume averaging, whereby if you have calcification that overlaps into another voxel, if it's particularly high attenuation, that might get either double counted, or if it's low attenuation, it may not get counted. So this one has a little bit more variability between the tests, just because you may, if you scan a patient twice and the patient's in a slightly different spot, you can imagine that those voxels are in a slightly different spot, and you may end up with a different number. So there's a little more variability with this method. And then there's something called a relative calcium mass score. And this relative calcium mass score, basically you calculate, again, the amount of plaque that you have, but you calculate it and multiply by the mean attenuation of the calcified plaque by the volume in each image. And you come up with this relative calcium mass score. And then this is corrected using basically a weighting factor for the attenuation of water. This is a little bit more labor intensive. You have to use a phantom to provide the calibration factor for your specific scanner. But it's a pretty robust method. It's generally not used a lot in clinical practice, but it is used a lot in research. So what is the prognostic value of these calcium scores? It's actually pretty high. So calcium is really an independent predictor of risk. So the higher the plaque burden, the higher the person's risk of coronary artery disease and the higher their risk of MI. If we look at a plaque, it actually goes through a typical progression. So you start with the interior of an artery where you might have macrophages that are active, and then you move to what we call the fatty streak. So if you were to look at these under a microscope, a fatty streak is just this kind of intracellular lipid accumulation. You wouldn't see this on a scan. You may not see that, you're not going to see this in a cath. It's really a microscopic definition. And then as it moves from a type 1 to type 2 to type 3 and 4, it's really not until you get to a type 5 or atheroma that you're really seeing a significant calcification. This could be clinically silent coronary artery disease or could be overt coronary artery disease. So with a calcium score, you're really not testing for the early stages of coronary artery disease. This is already plaque that's calcified, and a pretty significant plaque. So a lot of the data that we have about outcomes for coronary calcification is based on this really large study called the Multi-Ethnic Study of Atherosclerosis. Think of this as kind of being like a Framingham heart study. So it's a really big cohort. And this is a prospective cohort of patients with subclinical cardiovascular disease. So in this cohort of patients, they collected a ton of information on them, including their risk factors for progression and clinically overt coronary disease. So this is a cohort of over 6,000 patients, men and women, kind of in an age range 45 to 84. And if you look at the makeup of this group, it's actually pretty good as far as diversity. So 38% white, 28% African American, 22% Hispanic, and 12% Asian. So it's a little bit more representative than what we see of many studies, which are, like, as we know, predominantly white men. So it's a pretty good cohort. And in this group, they measured calcium scores at baseline. So this is all from around 2000 to 2002. And they actually measured the calcium score at baseline for all of these patients. And then they measured it again at 2 years. And then they all got measured again at 5 years. So they have a lot of data points. And one of the helpful data points that came out of this is something called the MESA calculator. So this is a calculator that you can find online. So if you go in onto this calculator, you can basically put in the information for your patient. So say you have, in this one, I just put in a fake patient, but a 53-year-old Black female, and then I made up her Agatston score as 125. So if you put this into the calculator, it basically gives you what percentile this patient is at for their calcium score. So a calcium score of 125 and a 53-year-old Black female would actually be at the 97th percentile. So if you compared her to all the other women of her age who are Black, she would have more calcification than 97%. So this is helpful. It's really helpful when you talk to patients. They kind of understand this, as long as you tell them that having a higher percentile is bad and not good. Then this is something that I find actually speaks to them. If you say, oh, you're at the 50th percentile or you're at the 90th percentile, it can be very motivating to patients for change. To tell them, if you compare to other, like say, oh, if you compare to other women your age, you have way more calcification of your arteries. I've found that to be very motivating to get people to do actual lifestyle changes or to take a medication. So if you look at how well calcium score is a predictor, you can see on this graph, so on the y-axis, it's cumulative incidence of major coronary events. And then the x-axis has years to event. And the bottom, like orangey brownish line is a calcium score of 0. So these are patients with no calcification of their arteries. And you can see that their event rates are exceedingly low. If you then go up to calcium score of 1 to 100, at least for the first 4 years, they're quite low. There's kind of a jump up around 5 years, probably from disease progression. But you can see with increasing levels of calcification that the event rates go up and up and up. So this is pretty helpful prognostic information. And it is at least validated in multiple racial and ethnic groups. And this just kind of shows a little bit more of the the clinical or statistical significance of this, that there really is a significant difference between these different cohorts. So if you look at different risk factors, so in the intermediate risk patient, there's all these different risk factors that you can look at. So if you have somebody who's an intermediate risk of coronary disease, there's multiple different things you can look at to try to figure out, okay, I have this intermediate risk patient. They're not low, they're not high. How am I going to treat this patient? You can look at multiple different things. One is a calcium score, one is a Framingham risk score, or maybe you're doing a C-reactive protein or family history. And if you look here, the coronary artery calcium score is the curve that kind of goes out to the left. So this has really is the most helpful to redefine somebody's risk if they're at intermediate risk. Each one of these has some incremental value, but the calcium score is probably the most helpful of all of these. And I just found this kind of interesting that up to 15% of people over 80 years of age have a calcium score of 0. So it's certainly not normal to have calcification when you're in your, in your 30s or 40s, but it's actually not as uncommon as you might think for somebody to have no calcification and be over 80 years of age. So importantly, where does this kind of fit into guidelines and consensus statements? So there's a consensus statement from the American College of Cardiology. They took 6 really large studies including 27,000 asymptomatic patients, and looked at the relative risk of major cardiovascular events for a positive calcium score and a calcium score of 0. And they found that with a calcium score, oops, it went too far. Let me go back. So with the calcium score of 100 to 400, the increased relative risk is about 4.3. From 401 to 999, you're looking at a relative risk of 7.2. And then over 1,000, that relative risk is about 11. So really a pretty impressive risk. And if they break them down into tertiles, you can see on the left, the bar on the left is tertile 1. This is a calcium score of 0 to 99. And if you look at the y-axis, it's looking at annual, basically cardiovascular disease, death, or MI rates. And it's exceedingly low if you have a low calcium score. So for patients with a calcium score of 0 to 99, it's 0.4% annual risk. So that's really low. So this helps you kind of reclassify your patients who are particularly low risk. And it goes up for each tertile, not surprisingly, the risk of cardiovascular death. So as far as the guidelines go, the clinical utility is really the highest in intermediate risk patients. So your patients who are high risk, this isn't super helpful for. They're already high risk patients. Getting a calcium score isn't that helpful. And this is mostly used, I know we have inpatient and outpatient APPs on here. This is really used predominantly in the outpatient realm for intermediate risk patients, but is also occasionally used in our inpatients. And as we do more and more coronary CTAs on our inpatients, you're going to see a lot more of these calcium scores come up because we do a calcium score with every coronary CTA. So you'll probably be seeing this come up a lot more as we do more coronary CTAs, since the guidelines have incorporated coronary CTA. So if you look at the 2013 guidelines, they recommend calculating the ASCVD pooled cohort risk to come up with this 10-year risk. Basically, what is your 10-year risk of having significant cardiovascular disease, MI, stroke, death, and you put it into this calculator. So this calculator uses age, gender, race, blood pressure, your cholesterol levels, and some other clinical factors such as diabetes, smoking, hypertension. For most of my outpatients, I calculate this score for them, and I usually do this with the patient in the room so that they understand what's going into this score and what things they can modify and what things they can't modify. In particular, I'll often click off the smoker one, and I'll tell them, like, I'll click off current smoker, and then if I'm trying to get them to quit, I will click off former smoker and tell them what the difference in their risk is, because there can be a significant difference in risk based on their smoking or not smoking. If it's somebody who doesn't smoke, then you're mostly looking at other modifiable factors, which are the cholesterol and blood pressure. So if you were to put in here a 55-year-old male with pretty good blood pressure, and you put in these cholesterol numbers, so a total cholesterol of 225, an HDL of 65, and an LDL kind of just above our top limit of normal of 135. I put this person in as history of diabetes, never smoked, not on antihypertensives. And you can kind of play around with these and come up with different things, but this would put this patient into the intermediate risk. Now, you could say anybody with a history of diabetes has basically an equivalent of cardiovascular disease and would be recommended for a statin, but often you have to try to convince patients to take things. So this would put him actually in an intermediate risk. So he has an 8.6% 10-year cardiovascular risk. His lifetime risk is 50%. I mean, this is just because, and I tell patients this, that coronary artery disease is still the #1 killer. So the lifetime risk of coronary artery disease is really high. And if you put in a male who's diabetic, it's going to be really high. Sometimes that lifetime risk scares people. So you put in those things and you come up in the intermediate risk range. So it's this intermediate risk group, which is defined as 7.5 to 20%. Those are the patients that are in this kind of intermediate risk. And then the borderline patients are 5.5% to 7.5%. So this is where the indication for, say, statin therapy is a little bit less clear. So you can use a calcium score to further refine their risk. So if they come up in this intermediate risk or borderline risk, you can use other factors to try to decide or help sway a patient to take a statin, for example. So for the calcium score, a calcium score over 100 Agatston units would reclassify that patient way up. So now this patient, instead of being in an intermediate risk, is definitely going to be over that 20% risk, and they would be indicated for a statin medication. Or if the calcium score is 0, that really brings them down, and that would be somebody who would not be indicated for a statin, for example. So their event rates, if you look at the event rates for somebody with an elevated calcium score, it definitely exceeds the benefit thresholds for statin medication. And patients with a calcium score of 0, we know have really low event rates. So then you kind of get into a shared decision making. Some patients just want the statin, and some no matter what, so they may want to take it anyway. And the calcium score is really the most useful one of these extra discriminating factors if you're looking at reclassifying patients compared to clinical history as far as family history goes or other biomarkers. So these are the 2019 guidelines, and it says for intermediate risk patients who are again 7.5 to 20% risk or borderline risk 5 to 7.5. A coronary calcium score is reasonable to help guide treatment. Now, getting insurance to pay for it is another question, and I'll maybe mention that a little bit at the end. And here's the algorithm if you're looking at primary prevention. So these are patients primarily in this 40 to 75 age range. So the patients who are younger than that, really the ASCVD risk calculator isn't really well validated in that group, and you're not going to put them into this same group. It's really only patients younger than that who have a particular reason to take a statin medication, and mostly family history or really elevated LDLs over 160. But for this 40 to 75-year range, if you have a patient who has an LDL over 70, less than 190, without diabetes, and the 10-year risk is in that kind of intermediate range, that's where you can consider a statin medication if one of these risk modifying factors increases their risk. So if the risk is uncertain, consider doing a calcium score. And then for patients with a calcium score of 0, no statin, you don't need it. For a calcium score of 1 to 99, it favors statin therapy, but that's kind of a little bit less strong of a recommendation. And then for patients with a calcium score over 100, initiate statin therapy. Does anybody have any questions or thoughts on calcium score as far as coronary calcium scores? And next I'm going to move on to a little bit about aortic valve calcification and the calcium score use there. Oh, there was a question here from Jean about beta blockers before a scan and heart rate. Beta blockers before a scan are needed for coronary CTAs. Typically not really necessary for a calcium score. I don't worry too much about doing these for calcium score, giving a beta blocker. For coronary CTA, though, yes, I give every patient a beta blocker before coronary CTA. Your calcium score will be a little bit better, but not significant.
This is Brooke Madden. I have a question.
Yeah.
So you've mentioned how the calcium score can affect your statin prescribing, but what about aspirin?
So aspirin is an interesting question. There is some data to show that patients with a particularly elevated calcium score can benefit from aspirin. I didn't include that because there really aren't guidelines to recommend it. And it isn't recommended in any guidelines as a kind of like way to decide about aspirin or no aspirin. And I don't think the new guidelines that came out from the US Preventative Task Force, I don't know that they mentioned anything about calcium score. I have had patients, if they have a particularly elevated calcium score, I do kind of go through the same bleeding risk benefit discussion with them. And I will often recommend aspirin if it is really high. For that, I generally wouldn't say like the 1 to 99, but the over 400 is a particularly high risk. Yeah.
Thank you.
Yeah. Sarah said, I had a PCP order exercise tolerance test, which was normal, but patient symptoms were concerning and a strong family history. Would you lean more towards a MIBI or a calcium score? So for patients who are symptomatic, the calcium score can be helpful if it's absolutely 0, but for patients who are actually symptomatic, you probably would just go directly to a coronary CTA rather than a calcium score so that you can see the actual lumen. There's a little bit of data, and some people will support using a calcium score for patients who are symptomatic, recognizing that in symptomatic patients, a calcium score can miss about 10%. So some people will say, well, if you look at population health, it's actually really pretty low, but it's actually in some studies upwards of 10% of significant stenoses would be missed because it's only non-calcified plaque. So the calcium score isn't looking at any plaque that is non-calcified. a coronary CTA will look at plaque that's calcified or not. So if the patient is symptomatic, I'm somebody who would lean towards doing a coronary CTA. There are some people out there who will say you can do a calcium score, and if it's absolutely 0, that might be enough. Insurance generally does not cover calcium scoring in most cases, no matter what, even though it's part of a lot of the recommendation guidelines. The cost is around, it depends on exactly where you get it. At Maine Med, I believe it's around $250 or $299, and some patients are willing to pay that out of pocket. It's better than their copays for a lot of diagnostic testing. But for that particular patient, I would probably get, if they had concerning symptoms, I would get a coronary CTA rather than either of those, unless you knew already that they had very high calcium burden, but presumably you wouldn't know that ahead of time. Jean asked, with a positive calcium score with additional risk factors, guidelines to cath if patient is without symptoms. There are not good guidelines to cath somebody if they have a high calcium score without symptoms. I've seen it done. I've seen it done because it makes providers nervous when you see a calcium score of 1,000, say, or 1,500 in somebody, and it makes providers very nervous to see that. But if the patient is truly asymptomatic, it is probably not indicated. There certainly are not guidelines to support doing a cath in that patient. If you really were worried and wanted to rule out, say, left main or PROX-LAD disease, you could consider doing it, but no, there are not guidelines to support sending somebody for a cath just because their calcium score is high if they don't have symptoms. You will get on the score, if you look at the breakdown of the results, it will tell you the total calcium score, but it also is going to tell you which vessels that calcium is in. I do take a look at that, particularly to see if the left main is calcified, because I think that is helpful to know. And that might be a patient that I would really probe a little bit more to find out if they truly don't have symptoms. All right. I think I have time to talk a little bit about aortic valve calcification. So aortic valve, we're all really quite familiar with the anatomy. Basically, the aortic valve has 3 cusps that are hopefully highly flexible leaflets that are made out of collagen fibers. Aortic stenosis, as we know, is basically progressive thickening and calcification leading to an outflow obstruction. And this is something that happens over the process of many years and follows a typical pattern where there's endothelial injury, lipid infiltration, and inflammation. Inflammation is always part of the whole calcification process. And this propagates until the calcification causes fibrosis and poor leaflet opening. So aortic valve calcium scoring, it's actually the same method as a calcium score for the coronary arteries. And if you order, say, a TAVR CTA, part of the TAVR CTA will be a calcium score. Usually the calcium score is done as part of that. And it's really quantifying the calcification on the leaflets. So it's the same software, same protocol. You're just scoring the leaflets instead of the coronary arteries. Same axial slices are used. And if you were the one actually doing this, they just have to be careful not to include the proximal coronary arteries or the anterior mitral annulus, because calcification there can get very close to the aortic valve. And multiple different planes are used to help differentiate exactly where that calcification is used, but it's the axial slices that are used to come up with the number. And this is primarily used to differentiate moderate from severe aortic stenosis. So if we look at our aortic stenosis patients, as we know, we have our classic aortic stenosis. Those are the high gradient aortic stenosis patients. And then there's our low flow, low gradient aortic stenosis patients and our paradoxical low flow, low gradient aortic stenosis. So this is an example of a classic aortic stenosis. So this is really defined by high gradients. So you have a high peak velocity over 4 meters per second. The mean gradients typically over 40. The aortic valve area should be less than 1 centimeter squared. And then an index is less than 0.6. And the dimensionless index, which is the ratio of the LVOT to the aortic valve VTI, less than 0.25. So if we look at how we calculate the aortic valve area, mostly done by the continuity equation. So basically a Doppler is placed in the left ventricular outflow tract. So you can get a peak velocity in the left ventricular outflow tract, and you get this nice Doppler, which is the one labeled LVOT VTI. And then you put a continuous wave Doppler through the aortic valve, and you get a similar tracing through the aortic valve. And this is used to calculate the aortic valve area and also the dimensionless index. So for our patients with low flow, low gradient aortic stenosis, this is defined as patients who have a low ejection fraction. So their EF is at least less than 50%, although you generally expect it to be much less than 50%. And you have a discrepancy between the aortic valve area and the mean gradient. So if you calculate the aortic valve area, it's going to be less than 1 centimeter squared. So the area is in that severe stenosis, but the mean gradient is less than 40. And these patients have a stroke volume index of less than 35. So this is kind of the definition of a typical low flow, low gradient aortic stenosis, where they just don't have a lot of flow going through the aortic valve because their ejection fraction is low. So they don't generate a high gradient. And so for these patients, again, at the top's the definition of classic low flow, low gradient aortic stenosis with the low valve area, but also low gradients. So the way we evaluate these patients through the guidelines, the first step is a dobutamine stress echo to see if the stroke volume improves, but then the next step down from that, I'm not going to go much through that dobutamine stress echo part, but you'll see the next part, which I've put in this red square here, is the aortic valve calcium score. So this a calcium score of the aortic valve can be used to help differentiate whether somebody has truly severe aortic stenosis or pseudo-severe aortic stenosis, meaning that the aortic valve would open if only their left ventricle could work well enough to actually generate some flow through that aortic valve. So it's not a problem with the valve, it's a problem with the ventricle for the pseudo-severe AS. And if it's really pseudo-severe AS, the treatment isn't to fix the valve isn't the problem, the ventricle is the problem, and those patients really just need heart failure therapy. But for patients that have a low EF, but also have a really poorly opening aortic valve, those are the patients who could be a candidate for either transcatheter or surgical aortic valve. And the cutoffs for these differ for men and women. So for women, the cutoff is 1200, and men, it's 2000. So this can help you differentiate whether or not they really have aortic stenosis or not, if they're in that low flow, low gradient. And then there's the other phenomenon, which as kind of my least favorite one, the paradoxical low flow, low gradient aortic stenosis. So these are patients who meet that same criteria of having an aortic valve area that's really low, but a mean gradient that also is low. But their ejection fraction is over 50%. So you would say, well, the problem isn't the ventricle here. The ventricle is pumping fine, why aren't they basically producing a gradient across this aortic valve? Is it truly severe? So here you have a discrepancy that's a little bit harder to figure out. The first step is to figure out if you have good data, but assuming that the data itself is good, the Dopplers are good, the measurements are done correctly, you come up in this basically group of paradoxical low flow, low gradient aortic stenosis patients where their stroke volume is low, but their ejection fraction is normal. So the classic patient that has this is like the little old lady with a tiny left ventricle. Maybe they've had hypertension for many years. They have a thick left ventricle. They have a really small actual cavity size. So their stroke volume with each beat is actually really low. And it's similarly low as somebody who has an ejection fraction of 35%. And these are the paradoxical low flow, low gradient aortic stenosis. So if we look at how to evaluate these patients, again, these are low aortic valve area, low gradients, low stroke volume index, but a normal ejection fraction. The first step is to figure out if there's a measurement error. And this will be about half of them. It seems like really just have a measurement error. And then the next step is to figure out if they're symptomatic. And if they are symptomatic, then you say, okay, we need to evaluate this further. Maybe this is true severe AS. If this is due to their hypertension and their blood pressure is not well controlled, fix their hypertension and then reassess. If it's not poorly controlled hypertension, then you can use the calcium score again, just like you used it for the regular low flow, low gradient aortic stenosis patients. It's kind of, and you can use that same number to try to decide, is this truly severe aortic stenosis or not? And this is important because for both of these groups, you're trying to decide if you should send them for an aortic valve replacement. So it's a pretty big deal if you don't get this right and they don't actually have severe aortic stenosis and you send them for a valve replacement. Not only have they gone through a surgery and a procedure, but they probably don't feel any better in the end. So this is kind of from a consensus document, the usefulness of the aortic valve calcification score to decide on severity. And there's a few different cohorts that they've looked at, and most of them come up with fairly similar numbers where the calcium score over 1300 or 1200, depending on what you look at for women, or 2000 for men is kind of the discrimination. In the interest of time, I'm not going to go through this, how it was derived, but basically they did look at a large cohort of patients who fit in this group and looked at different calcification scores for them. And they came up with this cutoff of 1200 for women and 2000 for men for severe stenosis cutoff. And there is a prognostic value to these. So whether you treat somebody who has an elevated score or not, there's a significant prognostic value. So it basically, it's helpful to treat patients who have an elevated calcium score, and it is not particularly helpful to treat patients who don't have an elevated calcium score because they probably never had severe aortic stenosis to begin with. And I think I'll just finish up there since we're basically at the end of the hour and see if anybody has any questions on calcium scoring for the aortic valve. Any questions on that? That's something that we certainly are doing much more frequently, both inpatient and outpatient. All right, sounds like it. No questions on that. If you come up with any questions or if you have any further questions about calcium score, either aortic valve or the coronaries, send me a text or email or anything and let me know. Happy to figure it out with you. All right. I guess everybody have a good day and good luck.
Thank you so much.
Bye.
Thank you.